Hello everyone. Let's start discussing abdominal examinations. And during my discussions, I will try to speak about any uh, common causes of any positive finding to help you address examiners' questions. So, the abdominal examination, as any examination, starts by general examinations. And as we talked previously in the cardiology and respiratory examinations, exactly same steps. We start by greeting the patients. Hi, introducing ourselves. Hi, I'm Dr. Ahmed Al Hadi, and taking permissions. I was asked to examine your tummy. Is it okay with you? And we also, it is important to ask about if they have any pain. Do you have any pain? Please let me know during my examination. I will try to be as gentle as possible, but if you feel any pain or discomfort, please let me know. And we start by having or taking few steps backward at the end of the bed and having a general look. First, start by the patient surrounding. Look for any vomiting bag, any drains, any stomach bag, any nasogastric tubes, and also if the patient has any medication at his bedside. And we will ask the patients, same as in respiratory stations, to cough and take deep breaths in and out. And we're asking them this to cough to just magnify any dilated veins and if they have any hernia. And then we'll go close to the patients and as we mentioned previously, we start with the hands, and in the hand we start by the nail first, and then go to the palm, and then pulse, blood pressure, and we have here in these abdominal examinations, we have arteriovenous fistula as well in the arm. So in the nails, we look for clubbing, which is could be signs of hepatocellular carcinoma, primary biliary cholangitis, inflammatory bowel disease, celiac disease, and GIT lymphoma. So clubbing could be signs of malabsorptive disease, such as celiac, inflammatory bowel disease, GIT, lymphoma. All of them cause chronic malabsorptions. And leukonychia, which is the whitish of the nail beds, it could be a sign of hypoalbuminemia, which is a sign of chronic liver disease and also in nephrotic syndrome. And we also look in the nails for colonychia, which is spooning of the nails in iron deficiency anemia and hemochromatosis as well. And finishing from the nails, we have a look at the palms. In the palms, we look for palmar erythema, which is signs of chronic liver disease. We look for Dupuytren contractions, which is signs of alcoholic cirrhosis and could also be familial. And we ask the patients to cock their wrist back, stretch out their arms and cock their wrist back, as we mentioned in the respiratory stations, are looking for flapping tremors. Flapping tremors, we find it in hepatic encephalopathy, in uremia, and respiratory failure type 2 as a sign of CO2 retentions. And then we look for any vitiligo, which is could be associated with other autoimmune disease such as autoimmune hepatitis. And if the patient has dark bronze skin, it could be signs of hemochromatosis. And also, we can look for rheumatoid arthritis deformities, which is in the abdominal station could be faulty syndromes, which combinations of rheumatoid arthritis, uh, splenomegaly, and neutropenia. And as I mentioned, we check the pulse and then we check the arteriovenous fistula, which is very important not to miss because the abdominal stations could be renal stations. So we have to look for any signs of arteriovenous fistula in the arms. And if we find uh, any fistula, we have to check if it is recently used by looking for needle marks in the upper part of the fistula. We look for needle tracks marks, which is for IV drug use. And if the patient is IV drug user, so they will be at risk of having hepatitis B, hepatitis C, and HIV. And we look for any process as is coagulopathy is a sign of liver failure. And in the axilla, we look for the axillary hair and axillary hair loss. It could be iron deficiency anemia or malnourishment or chronic liver disease. And scars of lymph node biopsy, also we could find it in the axilla, and acanthosis nigricans, which could be signs of GIT malignancy. So just summarize the hands again. We look for clubbing, we look for colonekia, which is spooning of the nails, and we look for leukonuclear, which is white nail beds. And then we look for in the palm for the between contractions and for palmar erythema. And we check for flapping tremors, and we look for any skin changes and then any rheumatoid deformities. And going up after checking the pulse, we look for any arteriovenous fistula as a sign of end-stage renal disease. And we will comment on any needle tracks marks if we find it. And then we inspect the axilla as well, looking for any axillary hair loss or any acanthosis nigricans. From the hands, we move up to the eyes as usual. So in the eyes, we have two important things we should never miss them in any station, which is pallor and jaundice. And also you can look for any signs of hyperlipidemia, such as exanthelasma, which could be signs of dyslipidemia or primary biliary cholangitis. And in the face as well, we can look for any signs of sarcoidosis, such as lupus pernio, or go down to the mouth. We look for cyanosis or any angular stomatitis, oral candidiasis. And also we can look for a very important not to miss ulcers in the mouth, which is signs of inflammatory bowel disease, especially Crohn. And then go down to the neck. So as you see, we following the exact, if you watch my previous videos, exact same steps which we followed in the post-respiratory and cardio. So going to the neck, the JVB, we should look in all stations, but JVB in the abdominal stations, unless the patient has heart failure, it would always be normal because the chronic liver disease and the portal hypertension, the pathophysiology is vasodilations, so it's expected to be low rather than to be high, the JVB. And then check in the face, we need to check the parotid glands, especially if the patient has between contractions, and alcohol is the most common cause of liver cirrhosis, so we need to check also for parotid gland, which is a sign of alcoholic cirrhosis. Also, if parotid gland is are enlarged, it also could be signs of infiltration by sarcoidosis or amyloidosis. We're finishing from the eyes, face, neck, going down to the chest and abdomen. So in the chest, we need to inspect for spider nevi. If they are more than five, like six spider nevi, it's indications of chronic liver disease. We also look for any hair loss and gynecomastia, which is due to increased level of estrogen, or actually it's because in the chronic liver disease, the liver functions is affected. So it will be like problem in of the metabolism of all the androgens. So it's a problem of the ratio of estrogen to androgen ratios. That's why the patient could have relatively high level of estrogens, causing them gynecomastia, and which is signs, as I said, of liver cirrhosis or liver failure. And gynecomastia could also be side effect of some medications such as digoxin and spironolactones. Going down to the abdomen, we should start by inspecting. And previously, we spoke in the general inspections for checking for abdominal distensions because it's going to be obvious, and we can look again for abdominal distensions. And then and full flanks. And then we look for very important to check for scars because it could be the only positive finding in your extensions. Just the patient has Mercedes-Benz or rooftop scars, which is the scars of liver transplants. And all the discussion will be about liver transplantations. So be mindful of scars. The most common scars we have the Mercedes-Benz liver transplant scar, and we have the renal transplant scar, which could be in the right iliac fossa or in the left iliac fossa. And also we can find the patient has a stoma bag with a stoma, which is ileostomy, if the patient has Crohn's disease. And also we check for caput medusa and dilated veins in the abdomen by inspections. And if the patient has abdominal distensions, the most common cause or we are concerned about ascites, but it could be like the patient could be obese patients, or constipations or gases, or female could be pregnant. So if you find the abdomen is distended, don't make up or invent a sign says the patient has ascites. You have to be very careful, and you have to be very careful when you check for shifting dullness. Because if the patient has organomegaly, when you're checking for shifting dullness, it also could be like a little bit tricky. Uh, and abdominal distensions, as I said, the most important thing we need to check if the patient has ascites or not. After inspections, we go to the palpations. And in the palpations, we have superficial palpations and deep palpations. So in the superficial palpations, we need to check in line different quadrants, and while looking at the patient face to check for any tenderness. And also we need to feel if there is any superficial masses or is any rebound tenderness or guarding. And which is sign of peritonitis. It wouldn't come in the exam, but the most important thing to check for tenderness. And the patient must be in the abdominal examination, should be lying flat. And then from after the superficial palpations, we go to the deep palpations to check for organomegaly. We have the liver, the spleen and the kidneys. This is the most important. So we start from the right iliac fossa to palpate the liver and the spleen. Both of them we start by palpating from the right iliac fossa. But when we come to the livers, we have to um, palpate twice, like for because you will be going palpating laterally from the right iliac fossa going up laterally, and then you need to palpate medially for the right liver loop. And if you find the liver is large, straight away do percussions and check for liver span. And for the spleen, again, we start from the right iliac fossa, going up toward the spleen to the left iliac fossa. And when we palpate the spleen and the liver, we need to ask the patient to take deep breaths in and out and keep feeling. And when you ask the patient to take deep breaths in and out, the aim is like when they take deep breaths in, the spleen or the liver would be touching your tip of your finger, so index finger. So you need to be very careful about when you ask the patient take deep breaths and out. When you move your fingers, it have to synchronize together, and don't rush. And for all, I'm focusing on my videos on the steps of the examinations. But you need to watch video which is showing the maneuver how to perform and perform it in your family members or in your patients. Uh, After we, as I mentioned, when I palpate the spleen or the liver, I need to percuss and see if they're tender or not. So to comment on my finding when I present to the examiner. And then the kidney, and don't forget them. I always forget the kidneys, especially if the patient doesn't have scars. So we need to do palpate the kidney by manually to look for any ballotment. And as I mentioned, the percussions for the spleen and liver, we do it straight away during our palpations. If the patient has organomegaly, we check for percussion straight away. And but in addition to percuss the organomegaly, we need to percuss for shifting dullness. So we start from the umbilicus going laterally, and then ask the patients to lean in our other sides and go backward again, checking for shifting dullness. And as I mentioned, please watch videos for maneuvers, but be mindful of organomegaly. If the patient has organomegaly, like for example, kidney enlargement or splenomegaly, you have to percuss in the other side, so to avoid confusions. After finishing all percussions, the last steps is the auscultations. So auscultation, we need to auscultate for hepatic venous hump in the epigastric area, which could be signs of portal hypertension or hepatocellular carcinoma. We need to auscultate for bruit. We have the renal bruit, we have the aortic bruits. The renal bruits, checking for renal artery stenosis, which is you auscultate for it around 2 centimeters above a lateral to the umbilicus, and we auscultate for aortic bruits just above the umbilicus. And also we need to auscultate for intestine bowel sounds, which is could be normal, like gurgling. We should be familiarized with the sound of normal bowel sound, or could be like tinkling, which is like very high pitch, high loud sounds. which is in intestinal obstructions. Or it could be absent, which is in ileus, paralytic ileus. So the bowel paralyzed, they don't produce any sound. And also, as I said, we check for hepatic bruit, which is could be signs of hepatocellular carcinoma. And then we'll ask the patient to sit up to examine the back. And I always delay the cervical lymph nodes to this point. When I ask the patient to sit up, it's easier for me to palpate for the cervical lymph nodes and axillary lymph nodes. You can do at the same time if time allow, but at least you need to do the cervical lymph adenopathy and the supraclavicular lymph node Bershaus, which is signs of gastric malignancy. And then inspect the back. The upper side of the back, we look for spider nevi again, and you look for scars down there, which is could be nephrectomy scars or percutaneous nephrostomy. If the patient has polycystic kidney disease, you will find also they have scars. In addition to the renal transplant scars, you will find in their back, they have nephrectomy scars. Sometimes they remove the old kidney or part of the old kidney to give space to the new transplanted kidney. And also, we may, if the time allow, because all the time is extremely limited in the exam, but if the time allow you, you could auscultate the base of the lungs to look for right side pleural effusion. If the patient has ascites, if the patient has moderate to massive ascites, they will have right-sided pleural effusion, so you need to listen for therapies in the base, lung base. And the last steps to check for sacral edema, which is also signs of fluid overloads. And this is our examination finished. But if you allow me, just I will tell you some few causes of our positive finding in our examinations to help you address the examiner's questions. So starting by hepatomegaly. The most common causes of hepatomegaly, we can summarize them in 3C and 3I. So 3C, cirrhosis, carcinoma, congestive heart failure, and 3I, we have infections, which is hepatitis B, hepatitis C, or the other I is immune related, which is like primary biliary cholangitis, primary sclerosing cholangitis, and autoimmune hepatitis. And the last I is infiltrative causes, which could be amyloid or myeloproliferative disorders. So this is the causes of hepatomegaly. We can summarize them in 3I, cirrhosis, congestive heart failure, and carcinoma, and 3I, infections, hepatitis B, C, immune, primary biliary cholangitis, primary sclerosing cholangitis, autoimmune hepatitis, infiltrative causes such as amyloid and myeloproliferative disorder. Right. So what the causes of splenomegaly? You can divide them by the size of the spleen. If we have massive splenomegaly, which is more than 8 centimeters, the cause could be myeloproliferative disorder, such as chronic myeloid leukemia and myelofibrosis. And also tropical infections such as malaria and visceral leishmaniasis. If the patient has moderate spleen, which is like 4 to 8 centimeters, the causes could be lymphoproliferative disorders or infiltrations by amyloidosis. And if the patient has mild splenomegaly less than 4 centimeters, it could be also lymphoproliferative disorders or portal hypertension and infections such as Epstein-Barr virus, infective hepatitis, and infective endocarditis. to also be hemolytic anemia. Again, the causes of splenomegaly, we can divide it into massive splenomegaly, myeloproliferative disorder, chronic myeloid leukemia, and myelofibrosis, and tropical infections such as malaria and visceral leishmaniasis. Moderate splenomegaly, myeloproliferative disorders could also cause mild splenomegaly and could also cause massive splenomegaly because it depends on which stage the patient presented. So it presented early, the mild splenomegaly presented late, it will come with massive splenomegaly such as in myeloproliferative disorder, chronic myeloid leukemia, and myelofibrosis. And also uh, amyloidosis can cause moderate splenomegaly, and mild splenomegaly could be portal hypertension or infective causes, or hepatitis, or infective endocarditis, or hemolytic anemia. Then we finish with splenomegaly and hepatomegaly causes. We go to ascites causes. The most common ascites causes we can divide it because also I said 3C, cirrhosis, carcinoma, congestive heart failure. So the same causes of hepatomegaly, cirrhosis, carcinoma, congestive heart failure, this 3C, they can cause hepatomegaly and they can cause ascites. So make it easy for you. If the examiner asks you what is the most common causes of ascites or what's most common causes of hepatomegaly, we have the 3C, cirrhosis, carcinoma, congestive heart failure. And the most common cause of cirrhosis, I'm going to speak about cirrhosis causes now. So the most common cause of cirrhosis is alcohol in the UK. And also we have viral hepatitis B, hepatitis C. We have autoimmune primary biliary cirrhosis, primary sclerosing cholangitis, autoimmune hepatitis. We have metabolic causes, non-alcoholic steatohepatitis, hemochromatosis, alpha-1 antitrypsin deficiency, Wilson disease, and cystic fibrosis. We also have drugs such as methotrexate, amidones, phenytoin, and isoniazid. So again, the causes of cirrhosis, we have alcohol, viral hepatitis B, hepatitis C, autoimmune causes such as primary biliary cirrhosis, primary sclerosing cholangitis, autoimmune hepatitis. We have metabolic causes such as non-alcoholic steatohepatitis, hemochromatosis, Wilson disease, cystic fibrosis, and alpha-1 antitrypsin deficiency. We have drugs, methotrexate, amiodarone, phenytoin, isoniazides. And the last things we have the causes of unilateral or bilateral kidney disease. If the examiner asks you what the causes of unilateral kidney enlargement, or bilateral kidney enlargement, we have polycystic kidney disease, which is the most common cause, which will be in your exams, and renal cell carcinoma and hydronephrosis. They could be bilateral, they could cause bilateral or unilateral kidney enlargement. Thank you so much for watching. And if you have any questions, please ask me in the comments, and we'll be more than happy to address all your questions. Best of luck in your exam.